Good afternoon, everyone. Welcome to the Gairdner Global Health Symposium, Food for Thought, Insights from International and Canadian Experts on Nutrition, Policy, and Food Systems. My name is Paige O'Byrne, and I represent the Gairdner Foundation. It's a pleasure to welcome you all here, both those in Montreal in the room with us, and those joining us via webcast. We're delighted to have you here for an afternoon of discussion and insight on global and Canadian perspectives in nutrition. For our audience members in the room, we're offering simultaneous translation today. Please follow us on channel 1 on your headset, and if you don't have a headset but you'd like one, you can please visit the table outside the auditorium doors. We'd like to thank our partners and sponsors for their generous support today. The Institute of Philanthropy, the Government of Quebec, and the Canadian Institutes of the Canadian Institutes of Health Research. The Gairdner Foundation was established in 1957 and has spent nearly 7 decades celebrating and promoting the world's most impactful biomedical research. More than 420 laureates from over 40 countries have been recognized through the Canada Gairdner Awards. Scientists whose discoveries have shaped our understanding of health and transformed lives worldwide. Global health has long been central to our mission. By recognizing and convening leaders who work to advance health equity and improve nutrition and access to care worldwide, Gairdner aims to highlight the science and collaboration that drive global impact. In addition to today's discussions, Gairdner will also host André Briend, the 2025 John Dirks Canada Gairdner Health Award laureate, an inventor of ready-to-use therapeutic foods for a public lecture this evening here at Coeur. His innovation has saved millions of children from malnutrition and transformed global approaches to child health. We hope you can join us. I encourage you to join the conversation online today by following @Gairdner Awards on social media and sharing your reflections throughout the day. With that, let's begin. Our first session sets the stage by exploring the global nutrition landscape, how international partnerships are shaping policies, practices, and innovations that improve health outcomes around the world. Please join me in welcoming Dr. Anna Lardy, Professor of Nutrition at the University of Ghana and former Director of Nutrition at the Food and Agriculture Organization of the United Nations. Welcome, Anna.
So thank you very much, Lana, for the introduction. And I thank the Gairdner Foundation for inviting me to be part of this celebration of the awardees, the great achievements, and I congratulate them. It is a pleasure really for me to be here. Canada is almost like second home for me, having done my undergraduate and also graduate studies here in Canada, but in Ontario. So one of the people we are celebrating is André Briend. We've known each other for about 20 years. And so I met him in Paris just in August, and we took this picture. And I told him I will be here to celebrate with him, so I'm here. So I congratulate you for the work you've done with saving lives. You know, your work with ready-to-use therapeutic food has really impacted on lives. You know, children who have severe malnutrition are being saved. And out of your work, you know, we also did other studies. I refer to it as baby RUTF, something that children whose diets are not adequate, you just add this to it, and then it will improve the quality of their diet. And we did studies with our UC Davis group, whom, of course, you know very well that you introduced and brought together on this work. And we've done these studies also through a lot of your innovation. And so all the children are saying that, thank you very much, André Briend, for your discovery. Okay. So let me go on to my presentation for today. Basically, I would like to start with a little bit of history in terms of where global nutrition policies have come from and where we are moving currently regarding policies around nutrition. You know, in the 1940s, there was an increasing global hunger and malnutrition due to the World War II effect on agriculture and food production, natural disasters, and widespread poverty. So with this, in 1943, there there was a big conference, that's in Hot Springs, Virginia. This conference was attended by about 44 countries. And looking at the global hunger and famine around the world, they came up with a declaration that the goal of freedom from want of food, suitable and adequate for health and strength of all people, can be achieved. So it was possible that the world can address the issue of hunger and malnutrition. To do this, they requested the formation of a permanent organization in the field of food and agriculture organization. So that was when FAO was born in October 16, 1945. So FAO is like the situation where the child is older than the mother. So the mother UN was formed after FAO. So certainly FAO is older. But one thing that is very interesting for this organization is that the first Director General was Sir John Boyd Orr, and he's a renowned nutrition scientist. He was at the time doing studies on the quality of diets and accessibility, how people, affordability of these high quality diets to especially the poor. And he became the first Director General of FAO. Now, when the mandate was given and the organization was formed, the mandate was to raise levels of nutrition and the standards of living of people, and also to improve the efficiency of agriculture production and distribution. So the mandate did not separate nutrition from agriculture. It was actually together. That was the mandate that was given. But over the years, a lot of things happened. Heavy focus on hunger only really changed a lot of the policies. We saw, because there was need to fight hunger in the 1950s and 70s, we had the Green Revolution, which really saved people from famine, but it focused on high-yielding cereals. There was also heavy focus on hunger elimination. Agricultural policies in many countries became more focused on food production, staple food production, especially cereals and staple crops. In the 1980s to the 1990s, the narrative shifted a little bit to include access, because you're producing the food and people cannot have access, they cannot afford it. So that was when the FAO's definition of food insecurity or food security changed to include access. People should have access as part of food security. And then with that, then came issues about poverty reduction and social protection measures, because you have to help people. Not everybody has equal access. So you have to build equity into the system and help some be able to have the ability to access the foods. Now with time, agriculture and nutrition, as I said, there was a separation. We saw the link between nutrition and agriculture became weaker and weaker. And nutrition programs were really placed in many countries. Nutrition programs were placed in the health sector. So health sector interventions had very little engagement with agriculture. So the link started happening. Now, we are seeing, a lot has happened in between. Now, in the current times, we are seeing a shift onto food systems for nutrition. Now, it's not just only agriculture, it's too narrow to address nutrition. We really have to look at the entire food systems. So now food systems have become a big thing. Now, according to me, one of the things that really placed food systems on the global agenda is this second international conference on nutrition. I joined FAO the year before, and this was one of my major assignments, to deliver on this conference together with WHO. This conference was well organized, attended by about 2,000 people, including the Pope, who was there, and everybody was interested. And I said that this conference was quite catalytic in making that shift and putting food systems at the center of addressing nutrition. At the conference, member states they made a number of commitments. Among them was to promote safe and diversified healthy diets. So we should look at diets as a whole to address malnutrition in all its forms. Now, over the years, even with a heavy focus on food production, we have not been able to completely eliminate hunger. In fact, we have not been able to eliminate it at all. You can see from the graph over the years what is happening. And COVID-19 exacerbated the situation. You can see during the period of COVID, the numbers went back up, clearly showing that our food systems have problems, they are flawed, they have weaknesses, they are not resilient. So the focus now has been on our food systems. The world is not on track to meet our hunger targets of the Sustainable Development Goal by 2030. And this graph is from the current SOPHI State of Food Insecurity and Nutrition 2025, and the world is not on track. When it comes to food insecurity, you can see the trends. And of course, you see how Africa sticks out. While in other regions, it's gradually coming down, but it should come down faster and better. But it's not. In the Africa region, the numbers are actually going up. So the world still has a serious food insecurity problem, and we really need to double up to really reach the targets. Now, to help the world get some targets to address, WHO at the World Health Assembly approved these global nutrition targets. The global nutrition targets by 2030, they want to see that the world is reducing stunting by 40%, wasting less than 10%, overweight less than 5% wasting, less than 5% overweight, and on. So you can see the targets there. Anemia, to be reduced by about 50%. So these are the targets the world has set and has been approved by the World Health Assembly that we should be aiming at by 2030. But again, an analysis that was done by SOPHI 2025 shows that we are far from meeting this target. This is 2025, we have only 5 years. So we really need an accelerated progress that will really get us to where we want to get to. If you look at the situation with diets, only about 34% of children in the world are meeting their minimum dietary diversity. Dietary diversity is a very important pillar of healthy diet. That's the number of food groups in the diets that one eats. If your diet is not diverse enough, you will not be meeting most of your nutrients. And according to the analysis that have been done by FAO and colleagues, and other agencies, 34% of children in the world are meeting minimum dietary diversity. Globally, when it comes to women, only about 65% of women are meeting the minimum dietary diversity. So access to healthy diet, it's a problem. So look at what is happening with our production. Now, if you look at the graph on my left, I don't know how you see it, we have how we should be eating. We should be having more, about 50% of our diet made up of fruits and vegetables, and the rest are in the quantities shown below, shown around it. But if you look at actually how we are producing food, our food production does not match the way we should be eating. You see that we are producing more of the staple crops, cereals and all, and yet only 17% of fruits and vegetables. So as it is, if we all have to go by the recommendation of WHO of 5 fruits and vegetables a day, the world is not producing enough to meet this guideline. Okay. So we are not matching. This is like a policy incoherence. This is how we should eat, and yet we are producing something else. And not surprising, healthy diet is expensive. And about 2.6 billion people cannot afford a healthy diet in the world. The numbers are high. They just cannot afford it. And not only that, we also have other problems that are coming up in the world. So the quality of the diet is becoming a problem. We're also having another type of nutrition, malnutrition that is happening. That's underway. This is a paper that was published in February 2024. And this paper looked at analysis that was done in several countries, 177 countries, and they found that the prevalence of obesity was higher than underweight in 177 countries. And their conclusion is that a healthy nutrition transition that enhances access to nutritious foods is needed to address the remaining burden of underweight while curbing the reversing increase in obesity. So we really need something that's like a double duty intervention that will address the undernutrition that is still available, is still around, and also the upcoming overweight and obesity and non-communicable diseases. This is a report that was released by UNICEF just last week. And they were looking at what is happening with children. And the report said that globally, obesity has overtaken underweight as the more dominant form of malnutrition among school-age children and adolescents. So another situation is emerging whilst we haven't solved the global undernutrition situation. This figure is from a paper published by Swanberg in 2019, looking at the global burden of disease. Basically, the question they were trying to answer is, what is killing adults the most in our current day and age? And whether you look at the data globally, high income or low income country, is poor diet that is causing problems for us. Poor diets are responsible for about 20% of premature deaths. Now, to go further, in 2019, the Eat Lancet Commission released a paper looking at food systems and healthy diets. They made a recommendation that I was part of the commission for 2019, but not 2025. 2025 report only came out about this October, 2 weeks ago. And in the first report, the analysis that was done, they found that if we are able to make dietary shifts, we can prevent 11 million deaths annually, preventable deaths annually, 11 million. The current analysis that was done based on recent data, the report that has just been released shows that we can actually prevent 15 million deaths annually, preventable deaths, just by shifting diets, changing the way we eat. And the recommendations are more fruits and vegetables, nuts and legumes, and reduction in the consumption of foods such as red meat and sugar. And that recommendation was made in 2019, and it still holds. So now let's come to the international partnerships in global nutrition policy. I've just said we see how complex the nutrition situation is. It's changing and all, and it's not something that only one partner can address. You need a lot of partners to work with. And we have opportunities for partners to work around this. The second International Conference on Nutrition that was organized in 2014 by FAO and WHO resulted in the UN General Assembly declaring the period 2016 to 2025 as a decade of action on nutrition. It's a time that all partners will come together to do something and really change the landscape for nutrition. This was supposed to end in 2025, but recently the UN General Assembly has expanded it to 2030. So it's going to go to 2030. The idea is that it's supposed to be like a catalyst to help us to achieve the sustainable development goals. We all know about the sustainable development goals. Goal 2, which is to end all forms of malnutrition and also double agricultural productivity. We all know about this. Now, there are the indicators for Goal 2. It's very interesting to note the indicators for Goal 2. Looking at the prevalence of undernourishment, more like hunger, the prevalence of moderate severe food insecurity, the prevalence of stunting, prevalence of wasting, malnutrition is wasting, prevalence of anemia. These were the indicators that came along with SDG 2 at the time it came out. The question to ask is, where are the dietary indicators? If diet is to prevent all forms of malnutrition, the indicators we have are actually the problem indicators. We wait and count stunted children, we wait and count wasted children, we wait and count anemic children. But we are not putting in the indicators that will prevent us from getting there. And one of them is dietary diversity, the diet indicator. It's taken a long time. We have not had a dietary indicator, but with a lot of nudging and pushing, finally, now we have a dietary indicator, the minimum dietary diversity for women and the minimum dietary diversity for children. And this was just accepted this March 2025. Okay, now let's look at also, there is a call to transform the way we produce and consume food. Okay. And this, we all have heard of the UN Food Systems Summit, which happened in September 2025. It was called by the UN Secretary General. That countries should look at their food systems. What are the issues with global food systems have problems, and how do we address it? So they came up with some action plans, and countries did so many things. Every country looked at their food systems and what needs to be done, and now many countries developed pathways. And in Africa, the African Union, in their 10-year strategy and action plan, is now focusing on Africa's agri-food systems. For the past 20 years, they have only focused narrowly on agriculture, but now they want to focus broadly on food systems. So this will cover 2026 to 2035. I'll say that many countries have also developed their own food systems transformation pathway, and my country, Ghana, we have also released our food system transformation pathways, what we will do to really transform the food systems in Ghana. So the partnership around the Food Systems Summit has trickled down to countries, getting countries to move. Well, there was a slide on nutrition, nutrition for growth. Nutrition for growth is a summit that comes on every 4 years. And the last one happened this March in Paris, and where they brought all donors, UN groups, philanthropies, all groups, all partners came around, and they made commitments to actually address malnutrition in the world. The commitments that were made amounts to about $29.3 billion were made, commitments were made to address malnutrition. Some countries made commitments in terms of policy commitments and programmatic commitments. Africa made about half of the commitments, financial commitments came from Africa, about 10.3 billion, majority of them from African institutions to really address the situation in Africa. Then you may also have heard about the scaling up of nutrition movement. This is a country-led, a country-focused movement that has been around since 2010, giving technical support and assistance to countries, especially low-income countries, to be able to change the situation of nutrition in the countries. And this has also been very, very useful in helping countries to move forward with addressing malnutrition. Because we have got to the point where we realize that partnerships are needed. No one group can do it alone. So with this, I'd like to end my presentation just by saying that we have a very complex global nutrition situation. We need partners to come together to really address the problem and get us developing, funding, and implementing the strategies that we develop to address the complex situation of malnutrition in the world. Thank you very much.
Thank you so much, Dr. Lardy. We'll now turn to Steve Gilbert, Chief Operations Officer at Nutrition International in Ottawa. Steve will share insights on how innovation and partnership can increase impact in global health and nutrition. Welcome, Steve.
Thanks, Paige. It's a pleasure for me to be here this afternoon as we honor Dr. Briend. Recognizes immense contributions to global health, and I'm grateful as well to the Gairdner Foundation for inviting me. Today, I'd like to share a few reflections on my own organization, Nutrition International, and our contributions to nutrition and global health, and most importantly, I want to talk about how innovation, collaboration, and scaling what we know works can transform impact and how we address global health challenges. But before I do, I wanted to share a story about a personal, somewhat tenuous connection that I have with Dr. Briend. In the early 2000s, I was working in Indonesia when West Timor faced a devastating nutrition crisis. One veteran from USAID had told me that he hadn't seen such severe malnutrition since Ethiopia in the 1980s. The region was poor, isolated, and still reeling from the violence of the succession of East Timor. Crops had failed after a prolonged drought, hospitals were few, and communities were dispersed, making outreach enormously difficult. Newly arrived, and at the time I had almost no experience in nutrition, I turned to the early internet. I actually went on Alta Vista, and so for young people, that was what we did before Google existed. And I typed in things like hunger, remote, severe acute malnutrition, community-based treatment, and I found papers on something called community therapeutic care that offered a lifeline. So very naively, I drafted a proposal to USAID based on this approach, and to my surprise and rising anxiety, the funding was swiftly approved. I had no nutrition team, so I quickly assembled one, and I even cold called a colleague of Dr. Briend, a gentleman named Steve Collins from Valid International, who thankfully agreed to come and guide us. What we implemented was essentially Dr. Briend and Steve's pioneering vision, and it worked. Many lives were saved in West Timor because of Dr. Briend's innovation. And I saw firsthand the transformative power of his ideas then, and I've seen it again and again in humanitarian settings around the world ever since. And that makes it truly humbling to stand here this afternoon as he is honored for work that has had such profound global impact. I wanted to share that story not just because it's yet another example of how transformative Dr. Briend's work has been, but because it highlights how innovation is central to achieving real, measurable impact in the world, and how collaboration and scaling proven approaches can make that a reality. Global health is facing many challenges right now, from shocks to the development ecosystem, the retreat of traditional donors, to increasing fiscal pressure on countries. If we want to make things better, and for as many people as possible, we need to scale up what the best evidence shows to be truly effective. But what's more, we need to embrace new approaches, new products, and new improved processes. Achieving this will require working together across borders, disciplines, and organizations to bring these solutions to their full potential and maximize their impact. But first, let me talk a little bit more about Nutrition International. We're founded more than 30 years ago in Canada. We are a global nutrition organization dedicated to transforming the lives of people living in vulnerable situations, particularly women, adolescent girls, and children, through better nutrition. With support from the Government of Canada, we work in more than 60 countries globally, generating data and evidence, supporting policymakers and institutions to make informed decisions. We then work alongside governments as an expert ally to ensure their programs successfully deliver the right nutrition interventions at scale to those who need them. We also generate and translate evidence into policies and programs, designing and testing innovative solutions and supporting governments and partners to bring those solutions to scale. This ability to bridge the gap between science and delivery is what allows us to maximize our impact and reach more than 500 million people each year. We recently launched our second investment case with catalytic funding from the Government of Canada. Designed to accelerate progress towards the Sustainable Development Goals and the World Health Assembly global nutrition targets that Anna presented, our second investment case is seeking to raise $1 billion for nutrition by 2030, and in so doing generate significant lasting social and economic benefits globally. Our drive to create lasting health and human capital impact at scale is part of who we are. It's in our DNA. Above all, we're here to reduce disease and help people not just survive, but truly thrive. The surest way to do that is by helping governments expand what we already know works while also embracing innovation, building new partnerships, generating new evidence, and unlocking new possibilities for healthier lives everywhere. Now, we've always believed that the best ideas come from collaboration. Students and faculty are often the ones who push the boundaries of knowledge, who ask the new questions, who imagine solutions the rest of us overlook. And we rely on your curiosity, your drive, and your courage to think differently. This is one of the primary reasons that we partner so often with academic institutions. Take, for example, our work with Harvard University's T.H. Chan School of Public Health. Together, we worked on the first ever estimate of the impact of prenatal supplementation on preventing non-communicable diseases in the next generation. And that's just one example of how collaboration generates evidence that can lead to impact. We also work with UC Davis, University of Toronto, University of Saskatchewan, the Sick Kids Center for Global Child Health, which was headed until recently by Dr. Stanley Zlotkin, who is also a Nutrition International board member, and even McGill, right here in Montreal, among many others. We work with many academic institutions in the Global South as well, of course. For example, the Kenya Medical Research Institute and the All India Institute of Medical Sciences. These partnerships drive innovation, generate evidence, and build the capacity needed to take nutrition solutions to scale. Again, the importance of innovation for creating impact and sustaining change cannot be overstated. It is fundamental. And over the years, Nutrition International has contributed to breakthrough initiatives that have changed the way the world delivers nutrition and addresses global health burdens. So like a proud parent, I could spend the entire afternoon talking about them, but because of time constraints, I will limit myself to 3 typical examples. One is vitamin A, another is double fortified salt, and a third is multiple micronutrient supplements. So the first, vitamin A, is perhaps the most widely recognized of my 3 examples. Vitamin A supplementation had been used to control blindness caused by severe vitamin A deficiency since the early 1970s. Clinical trials in the 80s and 90s showed that it could reduce all-cause mortality in children by up to 24%. In fact, it was a Canadian researcher, George Beaton from the University of Toronto, who was one of the authors of the meta-analysis that led the Government of Canada to create and fund Nutrition International in the 90s to scale up vitamin A supplementation globally. With generous financing from the Government of Canada, Nutrition International now leads a global partnership that ensures children in more than 50 countries receive life-saving doses of vitamin A. That means that every year, between 150 and 200 million children receive 2 doses of vitamin A. Now, along with vaccines, it is one of the most cost-effective ways to save a child's life. And since the start of the program over 30 years ago, the scaling of this innovation has saved more than 7 million lives. That, I think, is an astounding number, and it's a remarkable achievement that all Canadians should really be proud of. Now, my second example is double fortified salt, or DFS. And that's salt that has been fortified with both iodine and iron. This is another example of innovation and collaboration that eventually leads to impact. For decades, fortifying salt with iodine has been a global success story in the fight against iodine deficiency disorders. Building on this achievement, Nutrition International, together with our longtime partners at the University of Toronto, we applied the same idea to tackle another major challenge, iron deficiency anemia. We developed a stable and acceptable form of double fortified salt enriched with both iron and iodine. The idea was simple but powerful. Everyone consumes salt, so why not use it to deliver 2 essential nutrients instead of 1? When DFS proved its efficacy, stability, and acceptability in trials, Nutrition International worked with local governments to bring it to scale across India, helping millions access better nutrition through something as simple as salt. It is now integrated into the public distribution system in India, the world's largest social protection program, and it reaches more than 37 million people across the states of Madhya Pradesh, Gujarat, and Himachal Pradesh. Independent evaluation has shown that DFS not only reduces iron deficiency anemia, but that using the existing food distribution system enables us to reach those who are truly the most vulnerable. We are continuing to work with the University of Toronto and several local institutions in India, such as the St. John's Research Institute in Bangalore, to further optimize the product and improve how it is implemented at scale to enable even greater reach and impact. And now we're exploring using that same approach to address neural tube defects in Ethiopia. Maternal folate insufficiency pre-pregnancy is a primary cause of neural tube defects, such as spina bifida. These are severe birth defects of the brain and spinal cord that can result in early neonatal deaths or long-term disabilities. They're particularly prevalent in Ethiopia. In fact, it's actually 8 times higher than in neighboring countries. So mandatory large-scale folic acid fortification programs have successfully reduced neural tube defect rates worldwide by adding folic acid to staple foods such as cereal flours. Here in Canada, for example, fortifying white flour, pasta, and cornmeal with folic acid in 1998 led to an almost 50% reduction in NTD prevalence in Canada. However, using cereal flours as the vehicle for fortification is not viable in Ethiopia, where much of the population does not consume grains that are milled industrially. So in contrast, around 90% of Ethiopian households use iodized salt with support from Nutrition International. A study produced double fortified salt containing both iodine and folic acid at a central salt processing facility. The result is a high-quality product that can offer a more practical and far-reaching way to deliver folic acid to the Ethiopian population. Now, as part of this project, we've been collaborating with the Ethiopian Public Health Institute, UC Davis, the University of Toronto, and the Food Biotech Corporation to study the biological impact of this DFS on women's folate status, with the goal of reducing the risk of NTDs. Early results from a carefully conducted field trial are incredibly promising, and more information will be released in the coming months. Now finally, my last example is about MMS. Nutrition International has worked alongside governments to improve comprehensive maternal nutrition services, including iron and folic acid supplementation, or IFA, to prevent anemia as part of antenatal care. But recent evidence suggests that switching from IFA as the standard of care to multiple micronutrient supplements, more commonly known as MMS, would provide even greater benefits for maternal health and birth outcomes. MMS contains 15 essential micronutrients, including iron and folic acid. So building on the evidence, in 2020, the WHO released a context-specific guideline which recommended that governments undertake implementation research before scaling up MMS through their health systems. Nutrition International is working alongside governments to support informed decision-making about switching from IFA to MMS as part of their routine services. In Pakistan and Nigeria, for instance, we worked with their governments to conduct implementation research, identifying and testing implementation strategies in real-life settings to better understand the feasibility of introducing this new supplement into the health system. And we used human-centered design to develop and test solutions for improving program effectiveness. And building on this study, which ended earlier this year, we are now supporting the government of Pakistan on their journey from IFA to MMS at scale through the introduction of new training curricula, demonstration areas across the country, costed roadmaps, and more. Now, Nutrition International's MMS cost-benefit tool, which was created in 2019, is used by governments around the world to help determine whether they should transition from IFA to MMS. In fact, it was even used by the WHO to develop their MMS guideline in 2020. And this year, we're adding a new module based on refined costing information from our recent studies to help countries better estimate the full true costs of the transition and to better gauge the affordability and cost effectiveness of switching to MMS. Now, these are just 3 examples of how innovations can be taken to scale to create lasting impact. There are more, and many more on the horizon. But success hasn't only come from introducing groundbreaking new ideas. It has also rested on generating robust evidence for their efficacy and effectiveness at scale, as well as their cost effectiveness. Nutrition International's Health Economics and Nutrition Financing Group plays an essential role in this work, asking how resources can be used most efficiently and sustainably, and equipping governments with the evidence and guidance that they need to make informed decisions that deliver the greatest impact. Ultimately, the goal is to identify what works most cost effectively and how we can expand, strengthen, or improve it. But as we celebrate these innovations and anticipate those that are coming, we must also recognize the challenges brought on by the current funding landscape and development. As I mentioned in my opening, the current global health landscape is a challenging one. Resources are scarcer, donors are retreating, and countries are facing increased fiscal pressure. But the need remains immense, and in some cases it is growing. What does this mean? Well, as an example, about 5 million children under the age of 5 die globally each year from preventable causes, and almost half of those deaths are linked to malnutrition. Recent decreases in donor funding mean an additional 5 million children are likely to die between now and 2030. And even more will be stunted, will suffer poorer health outcomes, and struggle to reach their full potential. Other areas of global health face similar challenges. This reality makes maximizing impact and doing so as efficiently as possible more important than it has ever been. And at Nutrition International, this is our guiding principle, to ensure that every dollar, every partnership, and every intervention achieves the greatest possible good. And maximizing impact really means three things for us. First is targeting wisely by reaching those who are most vulnerable, most marginalized, and most at risk. We need to deliver efficiently by strengthening government systems so that they can deliver at scale for the long term. And we must measure objectively. We've got to be rigorous about what works, and accept what doesn't work and stop doing it, and look to where we can always do better. And we owe this not only to our funders and our partners, but to the people that we serve. And ultimately, this is what I hope that you take away from this afternoon, and the example that Dr. Briend has set for all of us. Innovation matters. It's not a luxury. It's a necessity if we're going to go do more with less, to reach those who are hardest to reach and solve the persistent and emerging challenges of malnutrition or any other aspect of global health. So now, as researchers, students, and funders, you are at the forefront of generating new ideas, new technologies, and new approaches. Whether it's through biomedical research, social innovation, or digital solutions, your work has the potential to change the way we tackle global health challenges. But it has to focus on impact, and it should be innovative and collaborative, and it has to build on what the evidence shows works. Now, all of the examples that I presented today were from a Canadian organization, drawing on Canadian expertise, working in partnership with Canadian institutions, and supported by Canadian funding. So this is why Canada is recognized as a global leader in nutrition, a field of proven strength and lasting impact that all Canadians can and should take pride in. Canada is stepping up, while others are stepping back, and you can be part of that. So, and if you are, Nutrition International wants to be your partner in this journey. We're open to working with you to test, refine, and scale up innovations that can make a real difference. If you're looking for a place where your ideas can move from evidence to action, from theory to practice, we invite you to reach out to us. None of us can do it alone. But whatever you do, and wherever you do it, please follow Dr. Briend's example. Be innovative. Push the boundaries of how we think and act, but strive for impact. Together, we can ensure that the next generation of breakthroughs in nutrition and global health reaches the people who need it the most. Because the true measure of success is not just that a single child will grow stronger, or a mother will deliver more safely, or a family will thrive, but that a whole generation will enjoy these benefits. Thank you very much.
Thank you, Steve, and sorry for the difference in our heights here and the problem with the microphone. Our next speaker is Dr. Thomas Drouet, Assistant Professor in the Department of Social and Preventative Medicine at the Université de Montréal. He will explore how nutrition can be more effectively integrated into community healthcare. Welcome, Dr. Drouet.
Is this good? Yep. Bonjour tout le monde, j'espère que vous vous portez bien aujourd'hui. Mon nom est Thomas Drouet. Hello everyone, in the room and online. Since there is a translation system effective today, I will take this opportunity to give my presentation in French. C'est un grand honneur pour moi d'être parmi vous aujourd'hui dans le cadre de cette série d'événements qui sont organisés pour la remise du prix Gairdner 2025 en santé mondiale au Dr Briend. C'est un accomplissement absolument remarquable et je suis vraiment très, très fier de pouvoir y contribuer aujourd'hui par ma présence et cette présentation. Le Dr Briend, comme vous le verrez, a produit énormément de travaux qui ont nourri mes réflexions dont je vais vous faire part au cours des prochaines minutes. Effectivement, je vais vous parler beaucoup aujourd'hui des agents de santé communautaire, du recours aux agents de santé communautaire pour traiter les maladies infantiles, particulièrement, évidemment, ça va inclure la malnutrition. C'est un bon moment pour faire le point sur cet aspect, comme vous allez le voir au cours des prochaines minutes. C'est un sujet sur lequel je travaille depuis une quinzaine d'années. Ça a retenu mon attention à la base en partant du recours aux soins pour le paludisme. Et je pense que c'est vraiment un sujet absolument essentiel pour améliorer la santé infantile. C'est un des gros défis auxquels on fait face. Avant d'aller plus loin, j'aimerais bien entendu remercier la Fondation Gairdner de m'avoir invité aujourd'hui à ce symposium. J'ai tout de suite un aveu à vous faire, je ne suis pas nutritionniste, alors j'espère qu'il n'y en a pas certains qui vont en profiter pour quitter la salle en douce. Ceci étant dit, j'espère pouvoir amener une perspective interdisciplinaire et nourrir la réflexion à partir d'un regard sur les systèmes de soins de santé. Donc, je vais parler beaucoup d'agents de santé communautaire, les ASC, aujourd'hui. J'ai mis mon timer parce que c'est un sujet qui peut m'entraîner bien plus que 25 minutes. Je ne veux absolument pas retracer l'historique des agents de santé communautaire, mais il est impossible de ne pas mentionner la conférence d'Alma-Ata qui a joué un rôle ici majeur en 1978, cette conférence sur les soins de santé primaire qui a littéralement propulsé ou mis à l'avant le rôle des agents de santé communautaire. D'emblée, ce que je tenais à mentionner, c'est qu'on va parler aujourd'hui beaucoup des ASC dans une vision thérapeutique. Un ASC qui prodigue des traitements pour des maladies ou des conditions, mais il y a d'autres rôles et d'autres missions qui ont été élaborées, qui ont été dévolues aux agents de santé communautaire. Il y avait un rôle à l'origine dans la perspective des soins de santé primaire, une dimension beaucoup plus sociale, de développement social, d'émancipation des communautés. On y reviendra, j'espère, dans la conclusion si on a quelques minutes. Un grand tournant dans cette mission thérapeutique qui a été octroyée de plus en plus aux agents de santé communautaire, ce tournant s'est opéré autour des années 2000. Comme je le disais tout à l'heure, la voie d'entrée, ça a été probablement le paludisme, les efforts de lutte contre le paludisme. À ce moment-là, les nouveaux tests de diagnostic rapide et les combinaisons thérapeutiques à base d'artémisinine ont permis vraiment d'envisager une prise en charge thérapeutique directement dans les communautés par des agents qui vivent dans les villages, des agents de santé communautaire. Alors cette stratégie-là, dès 2004, a été recommandée par l'OMS. C'était au départ Home Management of Malaria, puis après ça a été très vite renommé Community Case Management of Malaria. Très rapidement, des études, et il y a eu des réflexions en cours pour essayer de voir si on ne pouvait pas combiner, élargir le mandat de traitement dévolu aux agents de santé communautaire. Et c'est dans ce cadre que dès 2012, l'OMS et l'UNICEF ont élaboré et formellement adopté une nouvelle stratégie qu'ils ont appelée Integrated Community Case Management. Le Integrated, ici, fait référence au fait que les ASC étaient, dans le cadre de cette stratégie, amenés à prendre en charge non seulement les cas de paludisme, mais aussi les cas de pneumonie et de diarrhée chez l'enfant. Donc les trois maladies infectieuses pour lesquelles le fardeau attribuable de mortalité et de morbidité était le plus important chez l'enfant. Qu'en était-il pour la malnutrition? En fait, dès 2007, donc avant même cette stratégie ICCM, il y avait déjà une recommandation et une politique de gestion communautaire pour la prise en charge de la malnutrition aiguë sévère. Mais il y a quand même certaines nuances ici. Dans cette politique, dans cette approche, le diagnostic et l'initiation au traitement continuaient de se faire dans les centres de santé. Par contre, avec le développement des aliments thérapeutiques prêts à l'emploi, le traitement pouvait se continuer à domicile. Et donc les agents de santé communautaire ont été amenés de plus en plus à faire un petit peu ce rôle de pivot et à augmenter le suivi thérapeutique dans les ménages directement et aussi à augmenter le dépistage communautaire. Ça a été donc une politique qui était en place, en tout cas une approche dès 2007. Par contre, très rapidement, il y a eu un ensemble d'études qui ont examiné la possibilité d'utiliser les agents de santé communautaire pour directement poser le diagnostic et initier le traitement, faire le suivi du traitement de la malnutrition aiguë sévère chez l'enfant. Donc dès 2009, il y a eu une étude de vaste ampleur au Bangladesh qui a donné lieu à la thèse doctorale de Dr Chloé Pouet. Et il y a eu un ensemble, vous voyez ici quelques résultats parus dans les revues de ces études-là. Il y a eu un ensemble de projets pilotes qui ont été menés dans des contextes très différents, aussi bien sur le continent asiatique qu'en Afrique subsaharienne. Donc dans les années 2010, les preuves se sont accumulées. Le point à relever ici, à mentionner, c'est qu'il y avait une très grande hétérogénéité quand même dans l'ASC en tant que tel, les caractéristiques de l'ASC. Si vous allez dans certains pays, un agent de santé communautaire, ça peut être un villageois qui a un niveau d'éducation vraiment de base et à qui on donne une formation parfois de quelques jours et qui traite des cas à son domicile. À l'autre bout du spectre, dans la catégorie agent de santé communautaire, on retrouve parfois des agents du système de santé qui travaillent dans des cases, dans des postes de santé et qui ont une formation qui s'étale parfois sur plus d'un an. Donc, on a une grande hétérogénéité ici, une variabilité dans ce qu'on entend par agent de santé communautaire. Ceci étant dit, malgré la variabilité dans les études, les résultats étaient somme toute convergents. Très rapidement, il y a eu un faisceau de preuves comme quoi les agents de santé communautaire pouvaient montrer une efficacité au moins aussi élevée que celle observée dans les centres de santé pour initier le traitement et pour atteindre un succès thérapeutique. En fait, cette efficacité-là était même dans beaucoup de situations supérieures. Quelques difficultés ont émergé. La gestion des cas de malnutrition aiguë sévère complexe, qui reste aujourd'hui un sujet un peu à part pour les agents de santé communautaire, et le niveau d'éducation ou la prise en charge par les agents de santé communautaire. Donc, dans ce cadre-là, il y a eu une simplification au fur et à mesure dans les études de protocoles. On a testé des protocoles et des algorithmes simplifiés, qu'il s'agisse d'utiliser uniquement le périmètre brachial pour poser le diagnostic ou de combiner la malnutrition aiguë sévère et modérée. Les preuves ont continué dans le fond, et vous voyez ici, même après la pause de la pandémie, depuis 2020, au cours des dernières années, il y a encore des nouvelles études qui sortent et qui ont montré des résultats très intéressants. Je dis ça alors que curieusement, un des tout premiers, si pas le premier essai randomisé contrôlé sur le sujet, qui a été réalisé au Pakistan, n'a pas montré de preuves ici vraiment probantes. Donc l'efficacité n'était pas littéralement supérieure ou véritablement supérieure. Il peut y avoir des raisons à cela, il y a eu un grand débat, on n'aura pas le temps de l'aborder aujourd'hui. Ceci étant dit, beaucoup d'autres papiers sont sortis, d'autres études dans des contextes divers et ont montré la plupart du temps une efficacité supérieure pour la récupération des enfants si le traitement était administré par des agents de santé communautaire. Le coût-efficacité aussi était généralement un autre indicateur qui était très intéressant et pour lequel l'approche communautaire montrait des avantages indéniables. En 2022-2023, si je ne me trompe pas, il y a eu finalement une grande revue systématique Cochrane avec une méta-analyse qui a confirmé avec certaines réserves ces résultats-là. Et l'année dernière, quand je vous disais que le sujet était chaud, l'année dernière est paru le premier essai randomisé qui a montré une efficacité supérieure de la prise en charge thérapeutique de la malnutrition aiguë sévère chez l'enfant par des agents de santé communautaire. Alors, cette preuve expérimentale était évidemment attendue par beaucoup. Tout ce faisceau de preuves convergents a entraîné l'adoption en 2023 de nouvelles politiques, des guidelines de l'OMS, qui recommandaient officiellement, donc pour la première fois, si on exclut un peu la pause de la Covid et d'autres circonstances, d'autres crises, mais donc il y a une recommandation que le traitement de la malnutrition aiguë sévère se fasse par des agents de santé communautaire dans des contextes. Ceci étant dit, j'ai mis un extrait ici de l'énoncé. Le texte est, vous le verrez, assez prudent. D'abord, la recommandation est conditionnelle, on reviendra sur les conditions tout à l'heure. Et ensuite, le groupe d'experts reconnaît avoir discuté abondamment, ce qui doit être un euphémisme, et que le niveau de certitude des preuves est quand même relativement faible. Un bémol cependant, cette recommandation est donc parue en 2023, l'année juste avant que les résultats de l'ECR de 2024 au Kenya sortent. Ça a dû rassurer. OK. Donc, pour ce qui est du potentiel de cette nouvelle stratégie, que de plus en plus d'auteurs et d'experts dénomment ICCM+, et le plus ici fait référence au fait que maintenant les agents de santé communautaire, on leur recommande de prendre en charge non seulement le paludisme, les diarrhées, la malnutrition, mais aussi la pneumonie, mais aussi la malnutrition aiguë sévère. Alors, le potentiel, on l'a très très brièvement vu, survol rapide. Les effets pour la récupération de la malnutrition aiguë sévère sont démontrés. Il y a d'autres points, il y a d'autres forces dans le fond à cette approche. Le premier aspect, c'est qu'il y a assez peu de risques. Et je fais référence ici à des effets inattendus ou des effets néfastes. On est très loin de la situation où il fallait des recommandations d'une prise en charge thérapeutique pour la pneumonie ou pour le paludisme, où il y avait évidemment un grand risque d'encourager le développement de résistance. Alors ici, ce risque-là n'est pas présent, et donc c'est un avantage pour étendre l'approche à la malnutrition aiguë sévère. Un autre avantage, c'est que les études les plus récentes semblent montrer que rajouter la prise en charge de la malnutrition dans le paquet d'activités des agents de santé communautaire n'a pas un effet néfaste sur la qualité ou leur performance à gérer les autres maladies. Donc il n'y a pas comme un effet de vase communicant ici ou quelque chose comme ça. On peut, dans certains cas, rajouter le traitement de la malnutrition par l'ASC sans bouleverser la qualité et leur performance pour les autres. Finalement, un autre aspect qui facilite quand même grandement l'extension et l'adoption d'une nouvelle politique, c'est qu'il y a déjà, il y a une très bonne faisabilité opérationnelle parce qu'il y a déjà un réseau d'agents de santé communautaire dans de très nombreux pays et il y a déjà le protocole ICCM de base qui est implanté à diverses échelles. Donc il n'y a pas ici de gros défis en termes logistiques ou opérationnels à venir rajouter la prise en charge de la malnutrition aiguë sévère. Je parle d'efficacité depuis tout à l'heure, j'ai survolé ça. Il faut juste comprendre comment est-ce que se produisent ces effets-là. Qu'est-ce qui se passe concrètement? Pourquoi est-ce que c'est mieux un traitement qui est administré par l'agent de santé communautaire? Principalement parce que ça permet de réduire la barrière géographique de l'accès aux soins et de l'accès au traitement. C'est la distance. C'est une des barrières essentielles dans bon nombre de pays, particulièrement en milieu rural, pour avoir un accès à des traitements. Et en réduisant la distance entre le domicile, le lieu où le ménage vit et le lieu du traitement, en fait, il y a deux mécanismes qui s'opèrent pour le cas qui nous concerne aujourd'hui. Tout d'abord, ça permet d'augmenter la détection communautaire et l'initiation rapide du traitement. Et c'est un élément clé pour la récupération de la malnutrition aiguë sévère. On veut que des enfants émaciés viennent avec un niveau moins prononcé d'émaciation, c'est évidemment positif. Le deuxième mécanisme, c'est que ça permet d'améliorer le suivi au traitement. C'est encore une fois un mécanisme très important pour la malnutrition aiguë sévère, puisqu'on est très loin ici à la limite du paludisme, où on donne une pilule ou deux ou trois et le problème est réglé. Donc cet aspect-là de suivi thérapeutique est très, très important. Donc en synergie, ces deux mécanismes permettent d'augmenter la couverture à la fois du dépistage de la malnutrition aiguë sévère chez l'enfant dans la communauté et son traitement, et en plus d'augmenter le succès thérapeutique. Donc c'est pour ça que la recommandation et l'adoption d'une nouvelle politique en 2023 n'est pas quelque chose de mineur ou sur lequel on peut passer rapidement. Il y a un véritable potentiel ici d'avoir une intervention qui réduit de façon importante et significative la malnutrition infantile dans les milieux reculés et ruraux. Ce n'est pas la solution miracle. Okay. Et je vais, si vous me permettez, faire un peu l'avocat du diable, mais c'est seulement en vue d'améliorer et d'optimiser les chances de succès de cette nouvelle stratégie ICCM+. Pour le moment, on a assez peu de preuves sur l'implantation et la mise en œuvre des programmes ICCM+, dans des conditions réelles. Donc, à passage à l'échelle des pays dans des conditions réelles d'implantation. Il y a des études qui sont sorties en Mauritanie, au Mali, en Rwanda, en Éthiopie, mais les preuves sur la mise en œuvre et les défis sont encore parcellaires pour le moment. Ceci étant dit, on peut prévoir, on peut anticiper que les défis de mise en œuvre et d'implantation de la stratégie de base vont se répercuter et vont se prolonger pour la ICCM+. Et il est important de passer quelques minutes sur ces défis-là, je pense, qui doivent être surmontés si on veut optimiser le potentiel et atteindre un impact maximal. Le premier problème, ou le défi, on va présenter ça comme des défis, c'est mieux, c'est le recrutement des agents de santé communautaire. Et je ne fais pas ici tellement référence aux capacités des agents de santé communautaire, le niveau d'alphabétisation, tous des éléments qui sont très importants, mais avec les protocoles simplifiés et les algorithmes, c'est généralement un problème qu'on peut surmonter. Bien entendu, il faut des caractéristiques essentielles et de base, mais ce n'est pas l'unique problème pour le recrutement. Si on ne prête pas attention aux dynamiques de recrutement, on risque en fait de reproduire des enjeux d'iniquité. Iniquité de genre, iniquité de pouvoir. Et donc, le défi consiste ici à recruter des agents de santé communautaire pour lesquels la communauté a confiance, mais qui permettent aussi d'insuffler une forme de changement social. Et là, on en revient un peu à l'esprit d'Almata et la réconciliation entre une vision thérapeutique de l'agent de santé communautaire et une vision de changement social. Deuxième élément, la formation et la supervision des ASC. Ça, ce sont les deux conditions. Si vous vous rappelez, il y a quelques minutes, je vous disais que l'OMS avait, en 2023, donné une recommandation conditionnelle à la nouvelle stratégie. Les conditions en tant que telles, c'était celles-ci. Il faut une bonne formation des agents de santé communautaire et une bonne supervision. Ça pose des défis. Pourquoi ? Pour plusieurs raisons, mais notamment la formation. La formation n'est pas une opération coup de poing, où en un mois, on forme 15 000 ASC dans le pays et le tour est joué. La formation doit être répétée, il faut des séances de rappel, etc. Donc il y a toute une dynamique derrière, toute une logistique. La supervision, elle doit être continue et elle doit être opérée par des agents habilités à le faire et qui collaborent bien avec les agents de santé communautaire. Alors ces éléments-là sont essentiels. À peu près toutes les études qui ont examiné les stratégies de gestion communautaire des cas ont relevé ces deux dynamiques-là, ces deux éléments comme essentiels. Mais donc, vous voyez tout de suite, le défi, c'est qu'on ne peut pas avoir un réseau d'agents de santé communautaire qui agit en silo, indépendamment du système de santé, puisqu'il y a ces enjeux-là de formation et de supervision, entre autres. Il y a d'autres aspects. La référence pour les enfants qui souffrent de malnutrition aiguë sévère avec des complications. On le disait tout à l'heure, l'approche communautaire permet de réduire la barrière géographique. Oui, mais pas pour les cas sévères. Et dans ce cas-là, il y a toujours des références qui sont nécessaires vers le centre de santé. Et la barrière géographique est toujours présente. Donc il faut des approches complémentaires pour s'assurer que ces cas-là, ces enfants-là, puissent être référés et parvenir jusqu'au centre de santé. L'approvisionnement en médicaments et en intrants, un autre élément absolument crucial. Les études, depuis des décennies, ont montré que c'est très positif que l'agent de santé communautaire, dans sa communauté, ait un traitement, puisse contribuer à soigner des membres de sa communauté. C'est bon parce que ça augmente la confiance des membres de la communauté envers l'ASC et ça renforce sa crédibilité, sa confiance en lui, sa motivation. Là où le bas blesse, c'est quand il y a les ruptures de stock. Les ruptures de stock non seulement empêchent l'agent de santé communautaire de réaliser ses tâches, mais aussi vont miner sa crédibilité auprès des membres de la communauté, parfois de façon durable. Et la solution n'est pas de créer une filière d'approvisionnement en parallèle. Pourquoi ? Parce qu'il est incohérent et vraiment problématique d'avoir dans certains cas, ce qu'on a pu observer, des agents de santé communautaire qui avaient des médicaments, mais le centre de santé qui, lui, était en rupture de stock. Ça crée des problèmes, des tensions et des problèmes de gouvernance. Donc, ici, on ne peut pas faire l'impasse sur le renforcement des systèmes de santé et l'approvisionnement, le renforcement des chaînes d'approvisionnement à tous les niveaux. La question de la motivation et de la rémunération. La rémunération est un des aspects qui permettent d'améliorer la motivation des agents de santé communautaire. Ce n'est pas l'unique, il y en a d'autres. Mais ce que les études suggèrent, c'est qu'à partir d'un certain seuil, la question de la rémunération est incontournable. On ne peut pas s'attendre à ce qu'on ait un réseau de millions d'agents de santé communautaire dans le monde qui agissent de façon bénévole dans les milieux ruraux de pays à ressources très limitées et qui vont à eux seuls venir résoudre, ou en tout cas apporter une contribution importante à la réduction de la morbidité, de la mortalité infantile dans les milieux ruraux. C'est tout à fait envisageable, le potentiel est présent, mais ça vient avec un soutien et une reconnaissance du travail de ces agents-là pour garantir leur motivation et pour s'assurer d'optimiser le succès des approches communautaires. Finalement, cohérence, coordination, des enjeux très importants, eux aussi. Réduire la barrière géographique. La barrière géographique est un des facteurs essentiels dans bon nombre de contextes qui restreignent l'accès aux soins. Mais ce n'est pas toujours le cas. Il peut y avoir des variations, y compris des variations locales. Et là où la barrière géographique n'est pas tellement présente, ou bien beaucoup moins présente que d'autres barrières qui restreignent l'accès, ce n'est pas toujours cohérent d'implanter un réseau d'agents de santé communautaire et c'est parfois contre-productif. Donc ce sont des exemples qui ont été observés. Le manque de coordination, parfois aussi. Les agents de santé communautaire ont connu un engouement incroyable au cours des 20 dernières années. Beaucoup d'ONG, d'associations sont venues, avaient leur propre agenda, leur propre financement, leur propre réseau d'ASC. Et il y a eu des cas où des ASC parfois se superposaient ou bien alors des situations où les interventions n'étaient pas cohérentes. L'agent de santé communautaire était présent pour atténuer la barrière géographique, mais on atténuait la barrière monétaire dans les centres de santé en rendant les soins gratuits aux centres de santé. Donc, pour finir, les populations ne savaient plus où devait se passer le recours aux soins. Alors, pour conclure, les messages clés peut-être que j'aimerais vous communiquer aujourd'hui. Certainement, il y a un immense potentiel et les preuves sont là. Ça permet d'améliorer la situation et de réduire le fardeau auprès des enfants dans le monde. Par contre, le déploiement d'agents de santé communautaire n'est pas une intervention durable et efficace sans un renforcement des systèmes de santé. La résilience, on présente souvent le réseau d'agents de santé communautaire comme étant la grande force de sa résilience, et lorsque le système de santé connaît des difficultés, une crise humanitaire, la crise de la pandémie Covid-19, la crise de l'insécurité maintenant dans les pays du Sahel, etc., on a tendance à avoir recours aux agents de santé communautaire pour surmonter ces défis. Oui, mais jusqu'à une certaine limite. Les agents de santé communautaire sont un mécanisme de résilience, mais c'est loin d'être une solution miracle. Il y a des enjeux, notamment de qualité et de pérennité, et donc ce n'est pas un substitut au système de santé. Finalement, j'ai parlé beaucoup de barrières géographiques pour l'accès aux soins. Il y a d'autres interventions pour réduire ces barrières géographiques qui doivent être considérées, qu'il s'agisse d'augmenter le réseau de structures sanitaires, d'améliorer le réseau routier. Il y a d'autres interventions possibles et qui sont complémentaires. Et il ne faudrait pas oublier qu'il y a d'autres barrières aussi. Donc l'agent de santé communautaire peut tout à fait contribuer à lutter contre la barrière géographique, mais aussi d'autres barrières, incluant la barrière monétaire ou la barrière culturelle, etc. Donc c'est dans cette perspective-là que des soins de santé primaire intégrés, à mon avis, ont une voie de succès et pourraient contribuer à réduire le fardeau de malnutrition infantile dans le monde. Je vous remercie et une mention spéciale pour tous les ASC que j'ai embêtés depuis 15 ans et que je remercie aujourd'hui.
Merci Thomas. We'll now shift our focus to Canada with a panel discussion, Global Challenges in a Canadian Context. Please welcome our panelists and our moderator, Malik Batal of the Université de Montréal, who will introduce everyone and lead the discussion.
Thank you, Paige. Bonjour tout le monde. Bienvenue à toutes et à tous. Je suis très content d'être ici. Je suis très content d'être ici pour honorer Dr. Briend, que j'accueille à Montréal, parce que je pense que c'est ta première fois ici. Alors on est très content qu'on fasse partie de cet événement. The title of our panel is called Global Challenges in a Canadian Context. So before I introduce the panelists, I will just go briefly over a couple of things that I think are some important global challenges around food. For example, rising food prices, growing food insecurity, and the persistence of undernutrition alongside a surge in overnutrition. Together, they fuel an alarming rise in diet-related chronic diseases such as diabetes, which signals a multiple burden of malnutrition. Excuse me. Food itself is imperiled by climate change, the loss of biodiversity, armed conflict, political disruptions, and now tariff wars. The COVID-19 pandemic further exposed the fragility of our global food system as supply chains broke down and access to food became uncertain in many parts of the world. Canada, for its part, is a net exporter of food, with a trade surplus ranging between $6 and $36 billion apparently, depending on whether we count agricultural production or just food that is processed. Yet, despite this abundance, we run a production deficit in fruits and vegetables, the very foods that are among the most essential to good health. And also, we are part of the G7, which is a small club of the world's wealthiest nations, but we still struggle, and increasingly so, with food insecurity and the rising tide of diet-related chronic diseases. Nutrient deficiencies remain present in some populations, for example, anemia, vitamin D deficiency, vitamin A deficiency in some populations, and the disparities are stark. If you're Black in Canada, you are twice as likely to experience food insecurity as a non-Black Canadian. If you live in a remote First Nation community, that likelihood is 3 to 4 times higher, and your risk of living with diabetes is 3 times the national average. So today, to unpack these realities, but also to explore solutions that are equitable and sustainable, I'm joined by an amazing panel of colleagues, each bringing complementary expertise and experience to this conversation. We are missing one panelist, but I'm sure she's on her way. So let me first introduce, right to left, Dr. Lana Vanderlee. I had the order differently on my paper, so bear with me. Dr. Lana Vanderlee is a Canada Research Chair in Healthy Food Policy, Associate Professor at the École de Nutrition and Researcher at Centre Nutrice, Université Laval. Her work focuses on how policies shape the food environments that people experience every day. She examines the impact of government actions such as regulating food marketing, labeling, pricing, and availability on what foods are accessible and promoted in our communities. Her research also explores how power operates within the food system, including the influence of food corporations in shaping our environments and choices. Lana plays a global leadership role within Informas, the International Network for Food and Obesity Research, Monitoring and Action Support. And she leads Informas Canada, a national network evaluating and characterizing Canadian food environments. Welcome, Lana. We have next to Lana, Dr. Mary Labbé. She's a professor emeritus in the Department of Nutritional Sciences at the University of Toronto and director of the WHO Collaborating Center on Nutrition Policy for Chronic Disease Prevention. Dr. Labbé leads a pioneering research program on food and nutrition policy for population health. Her team analyzes large national surveys looking at what people eat, what they buy, and their health outcomes to entangle the complex relationships between diet and health. She also works directly with consumers to understand how they interpret and use food label information. And since 2010, she's maintained the largest database of brand name packaged and restaurant foods in Canada, called FLIP, the Food Label Information and Price Database. I love the acronym. FLIP allows governments and researchers to monitor changes in the food supply over time. It's now being used by the World Health Organization and by researchers in more than 15 countries across Latin America, Africa, and Asia to evaluate their national food supplies and advocate for healthier food policies. And finally, present today is Dominic Schofield. He is the co-founder and director of the Future Food Platform in Geneva and global director of agri-food systems at TechnoServe in the United States, supporting businesses and organizations in scaling social impact initiatives across more than 30 countries. Dominic is also a professor of practice at McGill University here in Montreal at the Des Hôtels Faculty of Management, where he advances the concept of food convergence innovation, a model for collaboration and transformation in food systems. He is also a professional affiliate at the University of Saskatchewan's College of Pharmacy and Nutrition. I will also introduce Trina Delormier, who is not here yet, but she is on her way. She got stuck on the Mercier Bridge coming from Ganawage. Trina is an associate professor at McGill University School of Human Nutrition. She's Canada Research Chair in Indigenous Food Sovereignty and Nutrition, and she is the director of the Center for Indigenous Peoples' Nutrition and Environment at McGill. She is the designated principal applicant of the Quebec Network Environment for Indigenous Health Research, which is part of a national consortium enhancing the Indigenous people's capacity in health research. She also chairs the expert panel on Indigenous science and food sovereignty convened by the Council of Canadian Academies. So I'll start now with the question. I'm going to be sitting. Hello? Yeah. To begin, I'd like to invite each one of you to tell us briefly about the angle from which they approach the food system. Can we start with you, Dominic?
Certainly. Thank you very much, Alec. And first, just to thank the Gairdner Foundation for inviting me to participate on this panel with such esteemed colleagues. I primarily work for a not-for-profit based in the United States called TechnoServe, as you mentioned, Alec. And what we've been grappling with is how to address food systems transformation from the perspective of making it more fair to the producers of food, fair to the business owners and others that are adding value to our food system, but also to do it in a way that leads to a more nourishing and healthy food system, something that benefits people in that regard. And then finally, to do it in a way that doesn't destroy the planet. Of course, we're falling short across all three of those, and I think there's a tendency to address each one of those ambitions in isolation. So what we're trying to do is to address them all together. And I think if you were to describe that ambition to anyone, everybody would agree, and we're probably all working in that way these days. I think the fundamental difference at TechnoServe is that we believe that that can't be achieved without a thriving business sector. And to be able to work with businesses to sustain that social impact is core to the purpose of our organization.
Thank you, Dominic. Mary, what's your angle?
Thank you very much. Thank you for having me here to join in the panel, and thank you for the Gairdner Foundation for organizing this with my panelists. So I guess I come from a different perspective, and I probably had a couple of careers in my life. And my early part of my career, I was a regulator in the federal government and director of nutrition. When I left the federal government, I had a job offer at the University of Toronto, which I've been there for a number of years now. I really took it from the light of how can we do research to help improve the food supply and the food systems. And really, knowing that I was in government in my early career, they need good evidence to support really public health policies to support the population. And I think what I really viewed and looked at my research is, originally governments really looked at, give consumers information, they should be able to make healthy food choices, reduce the risk of chronic diseases, obesity, and that. But in actual fact, they can't. And I think what we really have to realize is that in order to be effective policymakers, they need the evidence to say, how can we have a healthier food environment that really sustains healthier nutrition and healthier food intakes of Canadians? And if you don't have those choices there, and they're not affordable and easily accessible, you don't actually have good nutrition. So our research really started in Canada. And I think the other aspect that we use is, so we look at big databases, we look at what consumers are eating, we do research with consumers, but we also, as part of the World Health Collaborating Center, we also have a lot of the tools and the techniques that we developed in Canada, and we use it to collaborate with researchers in other countries. And many of them piggyback on some of the work we've done in Canada, and we really sort of build the infrastructure in other countries as well to help them get the evidence to also say that these really effective food policies are just restricted to the global wealthy countries, but are accessible, and the evidence is generated in those countries around the world. So that's sort of the approach that we've taken to healthy food systems. So it's one part of it.
Thank you very much. Elena?
Great, thanks. Well, I'll echo my colleagues here. Thank you so much to the Gairdner Foundation for hosting this event. It's such an honor to celebrate Dr. Briend and his accomplishments, as well as the accomplishments of our speakers earlier today. So it's great to be here. So a little bit like Mary, I did some training with Mary, so we have some similarities. But I focus on the food environment as part of the food system. And when I talk about the food environment, it's sort of a central component of the food system where consumers interact. It's where how they have access to food, how that food is promoted to them, what it looks like, what they understand about food. And so I try to understand areas within the food environment, and particularly policies. So what are the policies and what is the evidence that we can generate to understand what are the most effective policies? And we have policies that are recommended now from the World Health Organization that really focus on food environments to improve dietary patterns. So using policies as a real lever. I think the other piece that really interests me, and it kind of is associated with a little bit what Dominic said, and some of the pieces that I'm digging into and interested in are corporate power and structures of power within our food system, because what we know is that both within food environments more proximally, but in the food system even more distally, that there are real power imbalances in terms of who holds the power, and there's corporations and food companies, big food we like to call it, who hold a lot of power. And so they not only influence what is our food environment, what foods are produced and how they're marketed and what they cost. But they also influence the policies, because we know that they're often a barrier, that companies often don't have nutrition and climate change as their foremost priority. Their priority is profit. And so how we negotiate these power structures within the current food environment and food system, I think, are really interesting questions. And from a research standpoint, I work with Informis, this international network, and Informis has worked to create these rigorous, harmonized methods to measure elements of food environments, and increasingly a little bit more in food systems, so moving more towards a bit the supply chain as well in production. But part of what we talk about is using this evidence for accountability. So in our food systems, who is accountable for change? Because our current food system, our current food environment does not promote health, and it does promote, it destroys our environment, and it's not just and equitable. And so who's accountable for that? And when we create evidence and we create data that shows the problems, it's easier to hold people to account, to say we have problems and we're moving in the wrong direction. And Anna showed some of this evidence earlier that, what direction are we moving? That's how we hold governments to account. We have data on if we're achieving the SDGs, and we can do that within food systems as well.
Thank you. I'll ask you to keep talking. I have a question. So your research sits right at the intersection of food environments and policy, as you just explained. So from the monitoring that you do with Informas, what do we know about how Canadians experience inequities? Like, what are the things that you see that are related to inequities? And my next question, which is related, are there lessons from other jurisdictions, perhaps, that we can learn from?
Mm-hmm. So, I mean, we know that, as you described, Malik, there are significant inequities, particularly in diet. You know, everyone in Canada has pretty poor diets. That's pretty unanimous in terms of there's very few people who actually have what we would qualify as a very high quality diet. And when we talk about the sustainability of diets, we have much less data, but we don't have sustainable diets either. But we know there are significant inequities in terms of marginalized, vulnerable populations. We also know that there's inequities in access to food, so food insecurity rates, for example, are much higher among different populations. And even in our food environments, we have some data that where this is a bit of a data gap for us in terms of who doesn't have access to healthy food environments. And there are, again, lower socioeconomic status neighborhoods, which typically have a greater abundance, for example, of fast food restaurants, which we know is associated with poorer health outcomes. So we do have a little bit of data in some areas, in particular a little bit from Quebec. But what can we learn from other countries? I think that's a really interesting question. And there's a couple countries, this is an interesting situation where we have a lot in the global north that we can learn from our partners in the global south, because some of the policy innovation in this space is really coming from the global south. So maybe some of you have seen in Canadian grocery stores now on the shelf, we have these new front of package labels that indicate with a magnifying glass, that indicate foods that are high in sodium or sugar or saturated fat. That labeling scheme actually was developed in Chile. And they have this really interesting policy bundle. A bundle is a set of policies that are implemented at the same time, and what we're seeing is that those can be very effective because they're coherent and they're synergistic. So in Chile, for example, they put big stop signs. So we have a magnifying glass in Canada saying, take a look, but in Chile they said, stop, para. And so these are stop signs for foods that are high in calories, sugar, sodium, and fat. And along with that, they said, okay, if a food has one of those stop signs, it can't be marketed to children. So it can't have Tony the Tiger on the front of the Frosted Flakes box anymore, or it can't be on children's television. They also said, and those foods can't be sold at schools either. And they also, at the same time, implemented a tax on sugary drinks. So that's just one example of a nice policy bundle where we see some coherence, and the results have been remarkable in terms of shifting some of the quality of the food supply, in terms of shifting dietary patterns. So that's one really nice example from the Global South.
Thank you. And I guess there are other examples also. I think of Mexico and Ecuador. Ecuador put traditional food in the constitution as a way to promote and protect the food. Mary, I want to ask you, now we have the magnifying glass. Do you think in which direction will industry go with these regulations?
Well, I guess following on with what Lana said, there actually is good evidence of which way industry goes. And I think one of the advantages of these types of policies, there's a couple of advantages. The first is the bundling, which unfortunately Canada has not done, and I'll speak to that. So they've just focused it on packaged foods. But there are two ways that warning sign, or symbol they call it, that are on those foods works. First, it really does make it right front and center to consumers. You'll see it right in the front of package, whether that high-end symbol is on a food, and you might see two soups side by side. Obviously, there's evidence that shows that consumers will choose the lower, the food without the warning. Children notice it and say, oh, I can't bring that to school. That's not a healthy food. They told us at school. So that evidence is there that the consumer themselves make those choices to reduce their intake, in many cases eliminate, substitute those foods for the healthier ones that don't have the warning. So that's one way. But the other, actually equally important way that's been documented in Chile, we're seeing it in Mexico, we're seeing it in other countries, is not only do the consumers react that way, the food industry does. And it's not forcing them in the sense they can still put their food out with the warning on it, but guess what? They don't want it on the front. So we're actually seeing in many of these countries, we see reformulation. So the food industry reacts by actually producing a healthier food. And obviously the thresholds for those warnings are set at a certain level. So, you know, if they can, they reformulate to get below that threshold for sugar, below that threshold for sodium, so that they won't have to carry that warning symbol. Or they introduce whole new products, because we see that when we look at FLIP, that in many cases, excuse me, I was chairing the sodium strategy for Canada. In many cases, they didn't sort of tweak around with their sort of traditional product. They came out with a whole new line of healthier foods, lower sodium foods, less sugar in foods. And so you see two things happening. You see the gradual disappearance of some of those less healthier foods. You see the companies investing usually large amounts of money into introducing new foods. Those ones tend to be higher, better in nutritional quality. So that's a big thing, and that's a positive thing. The one thing that we're publishing some data, the last grant we had from CIHR was saying, well, what's the impact of these food policies on food pricing? And we all know that the cost of food is a big driver of consumer choice. And if you're talking about like marginalized groups, and you mentioned it in your opening remarks, and Gladys mentioned it, we all recognize it, particularly these last few years where we've had high inflation coming out of COVID, food pricing is an important question. And so we're seeing, and I would say, mixed results in terms of what's happening. We're absolutely seeing food pricing going up, but we're seeing it throughout many, many food categories. When we looked at something like sodium, we actually didn't see that much increase in food prices, but we saw very little changes. And the changes we did see tended to be on what I call the easy choices, and some people call it the easy things to do or the low-hanging fruit. So the things that were easy, less costly to do, just put a little less sodium in, not go to more expensive substitutes or big reformulations. Those are easier to do, don't have much cost implications, so we've seen some of that. But if we look at that market share I said, which changes, you gradually see some of the foods falling off and some newer ones coming in, then you actually start seeing that some of those newer introduced products are at a premium. So it's a mixed message, and we don't have enough data yet, and I think we just got a grant from CIHR this year to look at the impact of these front-of-pack labels, and the big questions was three things. How do consumers change their food purchasing? So will they buy less of those products if they have a warning on? What is the food industry doing? Like, how much are they reformulating? So we've got FLIP data now since 2010, so we'll know how those foods are reformulating. And thirdly, what's the price? And we can track, because we've tracked those years, it's not just the nutrition information, but the price of those foods. So that's really going to help untangle what's going on. So it's not just if they make the price and sell the food, but it's too expensive, they may not get the consumers to buy it and purchase it. So I think you have to look at those questions multiple ways to get the answer. But, you know, we're getting there, but I think there's great potential that we've learned from the countries that have done it. And I think in some ways, our magnifying glass isn't as strong as the soft symbol, but I think kudos to Canada, because we're one of the first, I would call, high-income countries where we talk about the power of the food lobby, where we actually got it through. And so that was a huge hurdle to get by. So, you know, still good progress.
Thank you. So Dominic, you know, food lobby, commercial determinants of health, and you talk about private businesses, but I think private businesses can be small, can be big. We forget that private business is also the farmers. That's a business too. So I want to like your take on that issue and how to promote having partnership with the private sector without falling into that trap of, you know, just profit.
Yeah, and that's a really excellent question, and there's so much ideology wrapped up in discussions related to who does what and who's accountable in food systems. If we think about the largest private sector in aggregate, it's actually all smallholder farmers and farmers put together. That's the largest private sector. It seems a bit slick to say that, but we forget that many farmers don't think of themselves as anything other than business people. And so making sure that they are good business people, that they have an opportunity to grow is a really important element of the dynamic that we're trying to build within food systems. Quite right that there are large multinational corporates that are particularly in the fast-moving consumer goods space or highly processed food space that are filling gaps around aspiration, but also around shelf life and low prices. And they put billions of dollars into innovating around what will hook people on taste. And so that there's an enormous power associated with that. One of the sort of things that we like to think about is, well, so what are the entry points? What are the levers that will allow us to fundamentally transition the food system to one that, Mary, you were describing, where businesses start to make the decisions that are more aligned with better health, better environmental stewardship, and fairness. And so to think about what the motivating factors are for these businesses that go beyond profit. You know, one of the challenges that Canada has is that there aren't a lot of Canadians, but we produce huge quantities of food for the world. And so, and we've seen this in other countries as well, in those kinds of contexts, Canadians tend to skim off of an economy of food that's being created that's actually intended for other populations. It's intended for income generation for the producers of those food. And as that machine moves forward, we skim off those bits that we want. So we exert very little power as consumers on the foods that are present to us. That's why regulation is so important in this country, because we need a heavier weight in order to balance some of the economics that are driving those sorts of decisions.
This is very interesting. I never thought of that. Like, the power is actually about commercializing the food and selling it. Which brings me to the power of our people, like the Canadians, to decide on our food. And I take advantage of you arriving to welcome you, Trina. And I realized that when I was introducing Trina, I didn't introduce her fully. I did not mention that Trina is a Ganegahaga woman, Mohawk from Ganawage, and that's why you were stuck on the Mercy Bridge. You were coming from your community. And, you know, you've been so much involved in, being director of CINE and other, CINE, that's the Center for Indigenous Peoples, Nutrition and Environment, and other roles you have played around Indigenous ways of looking at food. So how can we sort of reconcile how, food is perceived because most of it is exported and it's a commodity, and with the vision that we need to have as, consumers or maybe eaters of food, and how we can respect the food using the Indigenous lens that you are very familiar with.
Thank you, Malik. And apologies for being late. I actually didn't go on the bridge because it was crazy. I don't know, something was going on, so I came by the South Shore. But here I am, and I'm happy to be here, and thank you for the invitation to the organizers. Because of who I am and where I come from, Ganawage, and I grew up on the reserve, I was always aware that we were, Indians. Grew up in the 70s, and now we call ourselves Umwehumwe. And but I was always very interested in nutrition and health, and food. My grandfather farmed, and traditionally our people are planters. We planted primarily corn, beans, and squash varieties, but also hunted and fished. So I always had that value that these foods were important. It was important to plant, but I didn't really know why. I went on to study nutrition because a physician from my community said we had a lot of type 2 diabetes, and we needed dietitians to help out people manage their diabetes. But all of this questioning came, like, why do we have so much type 2 diabetes? And food was so important. Why aren't we eating the foods that we have as part of our ceremonies? And I came to learn that, the food that and this was through my work as a nutrition master's student, thinking about research and doing research on Indigenous people's food systems, is that these food systems are so incredible. And then, learning that many of the foods we consume today that are grown for sale or for commodities were cultivated by Indigenous peoples in North America and other places, and it gave me an incredible amount of pride. And so when I think about food and a worldview, I think what's very distinct about Indigenous people's food systems is that we see food as a relationship. In the language, in the Ganyogeha language, the word we use for food, and my grandfather told me this, is jonhekwam. And that's a verb. they sustain our lives. They're sustaining our lives, and that's all of the things that we consume, that we eat, plants and animals. And that's the word, they sustain our lives, and we give thanks to those life-sustaining beings because they allow us to live, and we have a responsibility to take care of those plants and animals. And I know in some ways of cultivating foods, the way people cultivate food, they might not be indigenous, but they also feel a stewardship or a caretaking responsibility to that. But for indigenous people, we have that responsibility. And what I've learned is that those food systems are incredibly provide complete and superior nutrition. The research that's been done more recently has shown that when people consume traditional foods on days compared to on days when people do not consume traditional foods, they're eating primarily food from the store, the nutrition profile is superior on many nutrients. So, nothing kind of is by accident, I was taught, in terms of how Indigenous people learn about the world they're in. We've learned how to respectfully learn about all of the species that sustain us. And of course, there are things that we favor, and there's other things that we probably forget because we don't have to eat them, like, maybe certain kinds of snails or insects that might be. But we knew we were in interaction with the environment and saw what would sustain us. And then I guess the other thing that I want to say with the food system is it's embedded in a knowledge system. So all of that understanding and knowledge has been acquired through close observation of the environment and then systematically passed to younger generations intentionally through ceremony, intentionally through roles and responsibilities of different age groups, and through kinship systems. So when you break down family systems or social systems, you're breaking down knowledge systems, which makes it very difficult to use and thrive in a food system. And if we think about Indian residential schools and different policies that have removed Indigenous people from their territories and then put them in educational spaces that don't allow Indigenous knowledge to be transferred, it's easy to appreciate why Indigenous people don't access their traditional food systems. And you can layer on other things like constrained opportunities to access education, to access employment, which are underlying poverty, which we know is a driving factor of food insecurity in this country. So I guess that's kind of my fascination as a researcher, as a scholar, is I've been so just always blown away by how sophisticatedly intelligent my ancestors are, and currently those knowledge holders remain. And I think that the sustainability of those food systems and the diversity within them are really models for us we have a responsibility to support that, but also to support Indigenous people's self-determination to eat those foods and learn those knowledges.
Thank you, Trina. I have a follow-up question. So, we have made some inroads in terms of the relationship between Canada and Indigenous peoples to repair some of the harm. But I don't know if we have learned as a country from what you have been describing in terms of how we look at traditional food. There are many barriers, like barriers between Indigenous peoples themselves and their food, but also, barriers between the rest of Canadians and how they can be closer to the food as you describe it, and have that. What, in your opinion, does it take to achieve that for maybe with your experience with the CCA currently in?
Yeah, I work with some my graduate students, and we talk a lot about reconciliation, and I see their frustration with seeing how things have to change and how little is changing in the places where they're learning. But I'm hopeful. I see a lot of things that have changed just in the past 20 years. So I think, education systems in, nationally, provincially, because education is actually in provincial jurisdictions, but with children, I've heard stories of children learning about Indigenous peoples, ways of lives, and are actually critical about what they're learning because they see that their textbooks are not really true. So I do see a lot of hope in the younger Canadian society through education, because I think there's it's through there we're learning about Indigenous peoples and what all of what we have to offer, in terms of just everything, food systems, knowledge systems, understanding of the environment, healing practices. So I think one of the ways is education for sure, starting from the youngest ones.
I have a follow-up question that I might like to ask. I have been doing a lot of reflection about the announcement that the National School Food Policy and our National School Food Program is going to be continued and hopefully perennialized now. And I'm wondering if you think that could potentially be a lever or an inroad, because I know, when I think about food environments, I worry that it could be, I have a great concern that my kids will just end up eating goldfish crackers and bear paws because that's what's going to be easy in these ultra-processed foods. But to me, it's also an opportunity, and I wonder if you think that could be a link with some of these Indigenous learnings and knowledge about food.
Absolutely, and I've talked with a few people in Quebec just to try to figure out how are some of those funds going to get to Indigenous communities. And I didn't find an answer, but there are people who are, similarly concerned about that. So that's one thing. I think the money has to get to the communities that could benefit from it, the Indigenous communities. And then, yes, definitely, if those programs at the community level are driven by the people themselves, the Indigenous people themselves, there's definitely a lot of opportunity. And I would love to see that there is interest. Always a challenge of enough resources because schools have a lot of their priorities, but I do think that's and maybe if there was clearly, and I don't have it at the top of my mind, but if that's within those policies that Indigenous communities, First Nations, Inuit, Métis communities, their involvement, their decision making should be part of that and valued. I think that would be great as well.
Thank you. Well, I'm going to flip the question and ask Dominic and Mary, because you both are familiar with how the industry works. What is, the degree of hope that you have around shifting the food system in that direction? I don't know who wants to answer first.
Okay, I'll start. I guess I'm always a glass half full rather than a half empty, so I'll say, even though my water's pretty dead empty here, but anyways, yes. I think I do have a positive attitude about things. We have absolutely seen some progress. We've seen, and I think, as I said, that shift that went for, quote, the responsibility and even the blame was on individual consumers. Governments have recognized that if they don't have policies and regulations, things won't necessarily change. And most governments around the world have been quite proactive in that space, and they can always do more. And I use the example, and Lana spoke to it about the front of pack labeling. So I think that is an example of something that's quite forward-looking policy that's quite, aggressive in a sense that nobody would have dreamed that we would have done that 10 or 15 years ago. But then I also look at, there's other policies, like there's been proposals that have gone out several times that said, we should restrict the exposure of children to unhealthy food marketing. Well, that policy has really gone nowhere. And I'm sure there's been some tremendous lobbying by very powerful actors in the food industry against it. But it's not just the food industry. It's the advertisers, whether it's the big sports teams and the sports franchisers, because food is big advertising. It's not just what you eat, it's what's on your TV, what's on your digital space. So I think that says that I'm positive, but I also know that there's real challenges, and so things haven't gone forward. And I think there's other area that in school foods, which you've spoken to, touches on that. A lot of the policies, like we see policy shifts, and policy migrates and gets, evolves on what we've learned, and then we build on the gaps we see. And I think another policy gap that from the food industry that's really big is governments have looked at a lot of these things around packaged foods. But none of these foods are focused on what we eat outside the home. And Canadians spend, quarter of their calories. Everyone eats outside the home at least once a week or more often. That's a big part of our food and our diets of Canadians outside the home. So there's no regulations, there's no front of pack labels on your menus in restaurants. There's nothing on those things. And I think school foods is that first, and I would almost say baby step into saying, let's start having healthier foods outside the home. And so not only do we have to introduce this national school food policies and programs, we also have to ensure that the foods that are offered and given aren't just, as Lana was worried about, just the easiest thing is to go out and purchase some of the least expensive, not necessarily the healthiest foods. So, so you can sort of say that yes, the food industry has helped us along. They may have hindered us, but I think as these programs roll out, the policy levers have to be strong enough to ensure that the food industry comes along with it and actually does deliver on the foods. And I give one example that happened a number of years back in the US. And that was about, whether or not they'd have chocolate milk in schools. And we heard those discussions in Canada too. And one of the things the Department of Agriculture did was said, well, if you're gonna have chocolate milk in schools, it had to be low in sugar. So the food industry did it, and they came out with a low sugar version. But they didn't offer it on the grocery shelves. So I think we really have to push, not only we get some policy wins, but push the policy wins to be broadly applied. And so as we roll out with front of pack on food labels and packaged foods, well, guess what? We need to all start learning how healthy easily some of the foods we're choosing outside of the home. We have to ensure that those school foods are the healthiest choices and not the easiest ones or the least expensive ones to buy. And I think knowing that governments are serious about it, I think food industry will be serious about some of those challenges too.
Thank you. Dominic?
Yeah, I'm also optimistic. You've got to be. I think one of the fundamental realities is that there's no one sector that's going to solve this problem. And we are seeing increasing collaboration across disciplines and across sectors. So that's a signal to me that the road ahead, while long, will still be filled with optimism. I think that the other thing that we're starting to see is that the accountability for change is also much more present, and not necessarily consumer-facing alone, but there are segments of society that are working together with common messaging around what we need. And part of the big challenges that we have, and this is not just in Canada, is that no one sector owns nutrition. Because of the way we've decided to structure society and govern ourselves, we've got ministers of agriculture, we have ministers of health, we have ministers of education, ministers of trade, and so on, and none of them own nutrition. But they all have a role to play. And to the extent that we can start to break boundaries down at that level, looking at policy coherence, which I think was mentioned before as well, is going to be very important, because that's what signals to industry that our society is serious about the changes that we're looking for. And at the end of the day, it's not governments, except for perhaps their school feeding, that deliver food to people, right? It's markets. It's the private sector that delivers it. So it's not an add-on issue. It's not now that we've got our policy coherence in place, now we're going to turn to the private sector and hopefully they'll follow through. There has to be engagement with the private sector in the way that we want to shape our future food system. So in that case, we're talking about innovation, and innovation that converges across a number of innovation cultures. Something that I work on with colleagues at McGill's Business School, food convergence innovation. This idea that there's a culture of innovation around technology. Lots of folks like to create widgets, or they like to reformulate food. There's a culture of innovation around business models, delivery models. How do you work? How do you get things done? That, interestingly, doesn't talk a whole lot to the widget people. And then there's a culture of innovation around social innovation. And again, they seldom speak to each other. The number of times somebody's come with a widget, a new product, gizmo, whatever, and said, okay, now how do I take this to market? Probably parallels the number of times that someone's come and said, now I can get appropriately costed, affordable product to a mass population, but what should I put in the basket? And they're not talking to each other. So starting to think about opportunities for us to bring these communities together, for them to be able to innovate together, putting people and the whole person to Trina's point earlier, at the center of that innovation. And then bringing a whole of society to the solution, I think, is what's really important. And we're already starting to see that.
Thank you. And to shift the emphasis a bit away from Canada, since we export so much food, how can these innovations you're talking about impact the world food system with all the inequalities that we see, all the food insecurities and the malnutrition, etc.? What can our role be as a country that exports a lot of food in that respect?
And a few years ago, with the interest of understanding what the future of food was, what plant-based protein looked like, and how do you formulate foods around that, and so on, I visited Saskatchewan and found out, to my surprise, that this province of about 1 million people supplied at that time 75% of the lentils consumed in India. So that suggests that we have a lot of power to influence diets. Now that's diminished significantly because of a whole range of trade constraints. But the opportunity for us to shape what's available, I think, is huge for such a modest population that is Canada's. When I was speaking to a captain of industry in Nigeria, we were doing interviews with companies, asking them, what they're producing and how much they pay attention to consumer demand and that sort of thing. And I asked the question, so what about consumer demand? And there was a pregnant pause, a little uncomfortable. And the CEO of this particular company, it was a large company, said, we decide what people eat. And so what is available? What is affordably priced? That's convenient. That is what is going to decide the quality of the diets that Anna presented in her earlier presentation. And so to the extent that we can shape that through trade, we can shape that through the assets that we have, we can shape that through the science that we're able to bring to the fore, but also the examples of policy coherence that we're starting to work with here in Canada and sharing those experiments and results across countries, I think is going to be an important role for us.
Thank you, and I totally agree. That's why we know that just talking to the consumer doesn't solve anything, because we choose from what is available, and what is available is usually sort of decided by other actors. And I usually give the example to my students about energy drinks. I remember a time when there were no energy drinks, and then that need was imposed by some industrial entities. So yeah, it goes in the other direction most of the time. So if we were to look forward, Mary, and based on all of this, what kind of bundle of policies would you recommend to a government, both for domestic and international impact, for a better diet and better health?
Oh, that's a hard one, actually. I think, in some ways, Canada can't impose anything on the world. In a sense, we hope that good practices can help, show models, provide evidence that others can use to leverage for change in their countries. I think one of the things that I actually give Canada credit for, back when they introduced the healthy eating strategy in 2015, which was actually fairly novel, in the sense it was right there talking about a bundle of programs. So at the time, the bundle of programs had, said we're going to have a new food guide. We checked off that one. We are going to, continue our voluntary sodium reduction targets. Well, we sort of checked that off, but it's not been very successful. We updated some of the food labels, so now you can see, for one example, with sugars. Now in the ingredient list, it'll say added sugars. There'll be a whole bracket, and all the ones that'll say your molasses and your sugar and your fructose and things that people don't even know are sugars, all listed in that list. We banned trans fats. Well, we were working towards it, but we got there. So, and now the front of pack labeling. So that was healthy eating strategy, which was the notion of no one policy is going to really change the food environment. But I think we heard from Anna, and we've heard from Dominic, and that was the Ministry of Health. We even saw that, maybe the Ministry of Agriculture wasn't on board. These types of programs, if you're going to talk about real bundling, in integration, well, that was an integration just at the Ministry of Health. But I think governments need to, as Dominic said, integrate food policies horizontally across ministries so that we have agriculture involved, we have education involved, we have taxation and food trade policies policies that all support healthy eating. And I think that's that notion which has not seen a lot of implementation, which is like that One Health. Like, you know, when we talk about food systems, it's the health of the planet, it's the health of the people, but it's also the health of the food industry and the, you know, jobs and employment. So, you know, we're not there yet, but I think that that notion of integrating is really, really important. Only one piece of the puzzle will only pick off a little bit of the solution, and we need much more of that thinking holistically and integrating it and thinking about not just one policy, but the policies then act synergistically. So they build on one policy, it has broader applications, it widens, and food industry really benefit by that because a broader application of policy really increases the motivation behind the scenes to innovate, reformulate, improve the food environment. So that's the way. And then I think, how does that globally? Well, I mean, some of the work we do for our collaborating center is working with other countries, you know, piggybacking some of that work. Obviously, capacity building. I mean, they need to drive their own policies in their own countries with the tools and the resources and the data from their countries. So, you know, if we can help and have models that they can use and go forward and collect their own data, and that's all part of it. But ultimately, I think you have to, and this work has to be done by the people in the countries with their own resources, with their own governments, and with their own, you know, academics, their own users to really affect change in other countries. We can't do it for them. They have to do it in their own countries.
Thank you. And I think Dominic and then Lana have some reaction.
Yeah, Mary, I'd like just to add to that, to your model of that kind of horizontal integration of policy coherence. I think one of the other opportunities that Canada has, in fact, is the work that we're doing at the municipal level in cities. So there's a policy coherence that also descends into where that whole person interacts with their food environment, which is often subject to a lot of municipal laws, municipal regulations, settlement patterns, and that sort of thing. And there's amazing work done by the City of Toronto, by Montreal, also in Saskatoon, where they're starting to explore policy coherence at that level as well. How does it show up in the home? Simple things like, if you want to have a community garden, do you need to go to the city and get an ordinance for festival use of water? Because that's the only access you'll have to fire hydrant that'll allow you to irrigate your garden. You know, just simple things like this that are in the minutiae, that are old, need to be reviewed as well. And there's some great examples of that work, again, in Toronto, Saskatoon, and Montreal.
I'll just put one little point. I did coordinate a public health policy program, and one of the things that in that course for students is policy is not necessarily top-down. There are many examples of policy being, you know, driven from the bottom up, but I think the biggest examples had, say, smoking policies, anti-smoking. Those start at the municipal levels, like in restaurants and cities saying, you know, employment opportunities. So we have to think that policy can, just like you say, can go both directions. It's not all from the top down, and in many cases, the activism at the local level is what really drives policy change, and then it's only when there's a groundswell underneath that actually that higher levels of government often won't act then. So, you know, Lana, you wanted to say to that?
Well, I just wanted to add, one of the policy pieces that we often talk about, are starting to talk about more and more, these double duty or triple duty policy actions, and acknowledging that it's not just about health and nutrition, but we can have policies that are actually beneficial to climate, that are actually beneficial to equity, to malnutrition, so over-under nutrition, as well as address food insecurity. So these policies that act at multiple points, I think, are really important. And the last piece I just wanted to mention, and Trina alluded to this as well, you know, we brought together researchers from across Canada who are doing food environment policy research to ask them to prioritize the most important policies that Canada could implement. And among the top 5 was a policy about creating a basic income guarantee for all Canadians. And I think it's important to remember that food policy is not always food-oriented, but social policy, strong social policy, social nets are also an important part of making sure that food is accessible and that everyone can access our food system. So that social policy piece is something that also is key.
That's very important, and I would add housing also, because unfortunately food purchases are elastic. People tend to cut on food and resort to lower quality food when they are stuck with rent and all the other expenses, including transportation. Trina, do you have any sort of policy hopes or?
Yeah, it was two things were crossing my mind as I was listening here, and the idea of policies are not always necessarily top down, and that you can have powerful policy solutions, call them, or policies coming from the ground up. And I'll use the example of Kahnawake, which had a health promotion program targeted for the schools, for the school children, elementary school children, and it was called Diabetes Prevention, Kahnawake School's Diabetes Prevention Program. And a part of that was was called a nutrition policy, and it banned junk food in the schools. But later we did an evaluation, and it was up to the teachers to implement it, and they didn't feel comfortable with that, and they implemented it in different ways. Some would take that away, the junk food, and give it back at the end of the day. So we learned a lot about doing these kinds of policies. And then it evolved into a wellness policy where there was a committee that was working to then implement that wellness. So it was beyond just food, but it included many aspects of well-being. So food became part of wellness, which was more in line with how we think about holistic well-being. And just today, I was talking with one of my students who's, she's developing an organizational readiness assessment tool to see if we could revitalize that health promotion program in the schools. And she's been doing a document analysis, and she said to me that the schools have done a consultation with the teachers and the students, and what they were saying, some of the things that they were important for them was having a healthy food policy in the school, or having healthy foods in the school. So that's coming from the students and the parents, and that's a result of this big change that has happened in the community as a result of the community working with researchers to develop a program that meets our needs, but also in a respectful partnership. So I think for me that's powerful, showing that even now we're working, trying to get the schools to be on side. And again, there's many new challenges in education than there were 30, 20 years ago, but that's still a priority. And then even in the community, when we see new development areas, there's a walking path that goes there. So I still want to find out which policy is making that happen, because I see it happening, but I don't know who's responsible. And then the other policy piece is Canada's food guide. There's a lot of critiques about that as Indigenous people don't see themselves. Even when we had the version in 2007 that did show Indigenous people's food systems, it still felt it was not, distinct or unique. But I think in the latest version, the guidelines that go along with the food guide, there was an effort to talk with researchers and experts about Indigenous people's food systems, and there is a whole section in there now that talks about the importance of those foods and how they contribute to nutrition. So that research is now being translated into these policy documents, so hopefully decision makers and health professionals are translating that information.
Thank you. I have a question about research, and the question is to all of you. If we had in front of us the people in charge of NSERC, SHRC, and CIHR, what are the research areas that each one of you would like to have more funding so that you can achieve the food system that you dream about? Dominic, do you want to start?
Sure. I think that there'd be a long list of topics that I'd get excited about that could be funded.
The top one.
Yeah. So I won't go through that long list. I'm actually going to shift because I'm sure the researchers here are going to be able to nail those down. I think a way of working is actually more important to me. And to work in a cross-disciplinary way. One of the key principles of a convergence innovation approach is around co-creation. And we talk about co-creation a lot, particularly in limited funding environments where different folks can bring a little bit to the table. But the co-creation is also often spoken about as a methodology. And I'd like to propose that we should think about co-creation not only as a methodology, not only as a way of sharing resources, but also as a moral compass. Because by co-creating, by bringing people together across disciplines, we can generate a shared value, shared benefits. We can facilitate or generate a collective agency as well. And a collective ownership. And fundamentally, you can't have transformation of any sort of system based on any kind of evidence if it's not owned and if it's not about changing behavior. So I would say that what I would like to see from the research community is a change in the way of doing things that gets us out of our silos and co-creates with a moral compass, not just a methodology.
Thank you. Who wants to go next?
I have one because I'm a policy nerd. I think one of the things that happens, and Trina just gave us a perfect example of, we have programs or policies or interventions that come up, and they come up from the ground up. They come up suddenly. A government announces that they're going to have a tax, or there's an innovative policy that bans energy drinks in a library. And then we have to wait for a full funding cycle in order to get the funds to be able to evaluate, to demonstrate that it works, and who it works for, and how it works, and how we can improve it. So if I had some sort of fairy godmother wish, I would wish for some policies, some rapid policy-specific funding that was agile. There used to be a really interesting program in the US, the NIH, that had that. So if there was a policy evaluation to be done, that was easily accessible. And I think that could help us generate the evidence of some of these unique programs and policies that come up to inform what we want to do.
Yeah, and I have a similar idea from the rapid response idea, but it's about working with Indigenous communities, First Nations, Inuit, and Métis communities. If you don't already have a relationship, it takes time to build a relationship with a community or communities in order to build the kinds of trust and assurances that it's going to bring mutual benefits to both the community and the larger scientific community of what we'll learn. And there are some of those development grants, but there's always a challenge with the timing of, if something's very specific, you have to kind of maneuver yourself to fit the call, and then hopefully you'll have the partnerships. And I guess things are changing. I lead one of the network environments for Indigenous health research. These are networks in each province and the territories. And we're focusing on enhancing capacity so communities can do research, be involved in research that meets their needs. And so having funding that acknowledges that capacity building in there as well, yeah.
And I'm going to add one more perspective, and I think I could take the blanket line that governments don't invest enough money in research, and I think it is true. The success rate at CIHR is pretty sad and pretty dismal, but it is what we have. But I think the other area that governments haven't done enough on, and I'll use for example our National Nutrition Survey, which is called the Canada Community Health Survey. The last one was done in 2015. So, the food supply that they built into that was probably in the, 10s, 12s, 13. So, surveys that Stats can do. So many of those data are the underpinnings, the foundations of the research that many of us conduct. And I think we also have to think about not only the amount of funding that goes to the researchers, but these very important national surveys that governments do, whether it's on income or food security or nutrition or health measures in the country, those are just as important as the census. Those are fundamental in understanding the drivers of, the factors, the risk factors, however you want to put it, of outcomes, but you have to measure both those risk factors and you have to be able to measure those outcomes. And those data sets are usually those data sets collected and operated and operationalized by governments. And I think they don't realize or not always realize how critically important those national data sets are. Food and agriculture, what commodities are we growing and selling and how much income they're bringing in, because those are all tremendously important in that whole research infrastructure in the country to recognize that investments have to be made just on not just individual researchers, but in those foundational data systems of a country to sustain a viable research program.
Yeah, the word investment is important. You're talking about investment in one area, but I'm thinking about how food and nutrition are perceived actually in terms of investment for health. We seem to not be heard as much. Do you have an opinion?
I have an opinion. The name of our research program is Food Nutrition Policy for Population Health. And I think, if you think about it, many of us all here work in the space of what I call, prevention, like disease prevention. And I think particularly in a country like Canada that invests so much money in our healthcare system, treating diseases, treating patients, and we know we don't have enough money. We say how our health systems can't keep up with an aging population, demographics. Well, proportionately, we need to be spending more on the prevention side, and a big part of that prevention. And I think Anna, you showed like a lot of those diseases all the way up. Like the diet is the biggest risk factor for most of the chronic diseases, and if we can't, invest in those types of things, and think we need the upstream investments in policies, healthy food systems. That's where we need to put some more investments to get the outcomes and the cost savings that come out. And I know you showed them even examples from the micronutrient initiative. There, those small investments up front have huge cost savings and benefits in populations and countries. And I think we have to look at that whole food system as that type of upstream work that has to be done to have those huge benefits downstream.
And I'll just add, I totally agree. I think we need more investments, and I think that having that data on dietary patterns would be fabulous, because so many researchers use that, and so many, it's not just researchers, but it's also, industry and others. And I also think, for me, I think there's also important monitoring that can be done by governments on food systems, because some of these upstream indicators, they're a bit easier to measure than behaviors sometimes, but we can measure things that are happening at the food systems level and the food environment level that will help us understand what's going on as well, and again, for that accountability piece. So I think that could be institutionalized by governments as well.
Did you want to say something, though?
Yeah, again, related less to topic and more to infrastructure. Mary mentioned data, and I think particularly with advances in technology that we have, we need to change the way we think about data and who owns it. And to perhaps explore a more federated system of data where the analysis goes to the data, rather than data gets gate-kept and owned by, whether it's individual researchers or institutions or whatever. Understanding, of course, that data is a currency, and there's an economics around that. I think it's really important for us to be able to build the infrastructure that Marie's talking about through a more federated system, a more distributed system of data. Again, where the analysis goes to the data. Everyone can own their own data.
Thank you. So we've been talking about, did you want to say something?
Yeah, I did. Again, from, when I teach public health nutrition to dietetic students and nutrition students. And I'm always really, every year when I have to teach the part about where do we, monitoring and things like that, I'm always really surprised at like how inconsistent and how long goes between getting these surveys done. So thank you, Mary, for bringing that up. And yeah, it's definitely important. The other thing I bring to their attention is that, there's populations who are excluded from those, like prison populations and military populations, and then First Nations living on reserve. So we don't have that information. And Malik, you know this very well, because the whole finesse studies were meant to fill that gap, right? So we have to also acknowledge that that data is, we don't have it for Indigenous people. So, but there's other surveys now that are being done to provide that, but they don't have the same information, so it's hard to compare. Yeah, so it's just to note that we get that information in different ways.
Yeah, I wanted to extend the question to talk about, if we look at nutrition and food as central for the health of people, it is also central for the health of the environment. And the way we produce food is very important in whether we retain our biodiversity, whether our soils are not, impoverished, etc. So on that end, what is needed, you think, Dominic?
Yeah, again, big question. If we had to pull together the amount of greenhouse gases that get emitted by food loss and waste in the system, it would be the third largest emitter after the United States and China. So addressing food waste and loss, I think, is going to be, should be a major agenda for anyone interested in transforming the food system from an environmental impact perspective.
Especially when we have such high rates of food insecurity, and having all that food be wasted is really a big contradiction. Any other thoughts? We'll be the last ones. I think we're nearing the end of our time.
Yeah, I mean, I think, like you said, our current food system is, has formidable challenges in trying to reduce these huge impacts. So I think one of the things that interests me right now is thinking a bit outside of the current system and of the current structure. What are the types of grocery stores that are operating outside of the regular definition of grocery stores? What are the community-driven? What are the territorialized food systems? How are we going to start to create something outside of this current system that could maybe be more regenerative, that could, have more positive environmental impact? So that's an area that really interests me, is what is the alternative to this? Because we can think about incremental change within the current system, but is there transformational change outside of what we're imagining right now? And I think that's where we need to start imagining a little bit and being creative.
I'll just add one brief note, building on what Dominic just said, is, obviously my career was built around nutrition and food policies and that, but I think we actually have to think about, not just how nutritious this food is, but what's the environmental impact of this choice versus this choice. Because I think, as we have more data and we get thinking about this more holistically, I think we're going to have to make these trade-offs saying, this may be a very nutritious food, but what's the environmental impact of making this choice versus. So I think we're going to have to start having a way of integrating so that consumers can make those decisions around those, whether there's trade-offs, but to get the both of both healthy nutrition at the minimal environmental impacts of those food choices. And we're not there yet, but I think it's absolutely what consumers are wanting. And I think that's an area that will evolve from a policy, but also to meet the needs of what consumers want to.
Yeah, and then building off of what you were talking, like out of the box, or not out of the box, but different ways of the dominant food system. When we talk about promoting Indigenous people's food systems, doing research, supporting practices in the communities, because this is what Indigenous people want to do, a lot of the support for that is that these systems are also very biodiverse. And biodiversity loss is something that's a huge issue, and having biodiversity in our food system is important. So these are examples, right? They're just models, and there's international models of different kinds of food systems, but that are built on, like I talked about earlier, Indigenous people's food systems and knowledge systems, but they're also economic systems and social systems. So at the same time, they're showing that they're models that we can use and learn from. It doesn't have to be a wholesale, but like just valuing that way of producing food. And for communities, they're also ways of sort of healing from a lot of the challenges that, in Canada and when we've had that colonial experience, to heal through the food where it's located in all the systems that keep us well.
Yeah, especially knowing that 70% of the food that is produced in the world is produced by small farmers in those sort of dominant food systems. So I like the radicality of your proposals there. We work also in Ecuador and Guatemala at what's the impact of, or what's the relationship between agroecology and the health of people and the health of the environment, knowing that agroecology has also social implications, gender implications, the health of, the mental health of the farmers and of the consumers. So all of these questions are perhaps important to keep in mind, not just, chronic disease, which is very important. As we know, everything is on the rise, particularly diabetes in Africa, for example. Rates are exponentially increasing. But so all of these, I think, are important issues. And I think we have reached the end of, if you have one word to end with each, or...
You've done such a good job, Malik.
Well, I can thank Gairdner for, in the name of everyone here, and thank people who are in the room and people who are online. Thank you very much, and I think that's it.
Thank you.
Thank you.